Just because you are told to code and bill a certain way by a urologist, it does not mean that you should do so, especially if that person is your boss. You should use your coding skills and apply them so that you keep him and yourself out of trouble. Today, we're answering another question from a member of the Thriving Urology Practice Facebook group. She direct messaged me with a question regarding vasectomy, what she would like to do with the billing, and what her urologist boss is telling her to do. So for those of you who have joined us recently, thank you so much for joining the Thriving Urology Practice Facebook group, where we crowdsource practice management solutions for everyone's benefit. My name is John Lin, and I'm your humble host of this group. Thank you all so much for sharing your questions and tips. And let's dive right into this coding question that this person has. She asked, "Hi, Dr. Lin. I have a coding question. We had a patient that came into the office for a scheduled vasectomy. Patient was seen by the physician's assistant in the same group several days ago, and decision for vasectomy was made at that time to proceed. Upon examination, the doctor found issues with the patient's right testicle from apparently an orchidopexy that was done by another urologist a long time ago. The doctor performs the vasectomy and wants to bill an E&M visit with modifier 24, modifier 57 on the E&M, and also modifier 22 on the vasectomy. Now, the biller goes on to say, I feel no modifier 24 because the urologist, or actually the patient, was not in a global period prior to the vasectomy. Modifier 57 is used because 55250, or the CPT for vasectomy, has a 90-day global period. However, the decision for surgery was not made on the day of the vasectomy. Now, the urologist did discover the testicular orchidopexy history on the day of the procedure and decided to proceed with the vasectomy after counseling the patient regarding potential difficulties. She, the biller, sent me screenshots of the office note as well as the op report for the procedure that was done and also the E&M visit in the discussion that took place. So the question is, can the urologist bill for an E&M visit and apply the modifiers? And also, we're going to talk about the use of modifier 22. So let's go into the easy one first, which is modifier 24 that the urologist wants to use in this instance. Now, that's easy because, as the biller said, there's no reason to use a modifier 24. Now, let's go over modifier 24's definition. And first of all, I'm going to applaud the urologist for at least trying, at least understanding most of what is going on. And I also applaud his efforts in trying to maximize his efficiency and trying to make sure that he bills for everything that he does. In this case, I think he's over-coding, over-billing, try too hard. So let's go over the definition of modifier 24. Modifier 24, if you read the CPT's description for the modifier, is an unrelated evaluation and management service by the same physician during a post-operative period. The physician may need to indicate that an E&M service was performed during a post-op period for a reason or reasons unrelated to the original procedure. And this circumstance may be reported by adding modifier 24 to the appropriate level of E&M service. Now, in the situation that was described by the biller, there's no modifier 24 event because the vasectomy patient did not have a surgery before, and the vasectomy patient did not fall under a 90-day global for you to need a modifier 24. the vasectomy patient was a new patient, did not have an operation by the same physician, same urologist prior to coming in. So there's no global that is needed, that the patient is under for you to require the use of Modifier 24 in this situation. So no Modifier 24, good try, but it is not indicated, not necessary. Now, the scenario is this. The urologist apparently has a PA who saw the new patient, the new vasectomy patient, went through the informed consent process and said that the patient should undergo a vasectomy by the urologist. Several days later, the urologist then performs the vasectomy or tries to perform the vasectomy. And when the patient comes in, the urologist does an exam and realizes, oh no, the right testicle, the right scrotum is going to be very difficult because of prior orchidopexy. And last year alone, I performed about 1,200 vasectomies, so I know about difficult scrotums. And yes, most vasectomy patients have virgin scrotums. You don't have to worry about tight scrotums, and most of the time, you can have the patient come in and you should be able to do the procedure on the same day. However, there are those patients who are morbidly obese or even some skinnier guys with very tight scrotums, and their vas deferens are very difficult for you to palpate. And sometimes it does require a lot of effort, and sometimes it's going to be very, very difficult to isolate the vas deferens. And so that is why I still haven't overcome the hurdle of still wanting the patient to come in for a physical examination so I can set the expectations for the patient when I perform the initial visit. I want to set the expectations so the patient knows what to expect, what to anticipate on the day of the procedure. And I have told many people, including urologists, that I think the most important visit when it comes to vasectomies is that first visit and not the day of the procedure. The vasectomy itself, I think, is easy, but I think just like dating, just like meeting your wife, getting married, setting the expectations about how you are going to manage money, how many kids do you want to have, how you are going to take care of your in-laws, that discussion is more important than the actual wedding itself. Likewise, when it comes to vasectomies, seeing the patient, examining the patient, setting the expectations, I think is more important than the actual procedure. In this case, the patient clearly had prior surgical history, which made it difficult to perform the procedure. And the urologist discovered that on the day of the procedure. Thus, he carried out extensive counseling, decided to go through the procedure, and then actually carried out the procedure. And I'll go over the actual procedure itself in a second. So he is thinking, well, I did this extra work right here on the day of the procedure. I should be able to bill for that extra work. Well, and he wanted to use different modifiers such as 57 and 24 and 22 and throw it all in there and see what sticks. Well, unfortunately, 24 is out, as we discussed. And now the question comes down to, is it appropriate for the patient, for the urologist to bill an E&M service for this particular patient who saw a PA just a few days ago, who then scheduled the patient to undergo vasectomy by the urologist within the same group? Okay, so the bottom line is you need to understand what is included in the global for that CPT 55250, which is a vasectomy. What's included in the global on the day of the procedure is making sure that the patient is an appropriate candidate on the day of the procedure, the performance of the actual procedure, including all the tools and instruments, and then the aftercare instructions and taking care of the patient afterwards on the day of the procedure. All that is included in the global package for that procedure. So did the evaluation and discovery of the difficult right scrotum on the day of the procedure constitute a Modifier 24 event? A Modifier 57 event? And the answer, bottom line, short answer is no. The decision for the procedure was already done by the PA several days ago, and you are in the same group. I applaud your effort to try to bring this out of the global package for vasectomy, but it is inappropriate to do so because your PA should have picked up on the difficult anatomy, should have done the examination, indicated to you, the urologist, that this may be a challenging procedure, and even better yet, you should have seen the patient, or ideally you should have met the patient on the day of the procedure. On the day of the initial visit, to go over that this may be difficult, that you may not be able to complete this procedure, and that it may take a long time, possibly requiring a Modifier 22 event, which we'll go over in a second. So that should have been done prior to that day of the surgery, day of the procedure. What you did on the day of the procedure is part of the global package for vasectomy. Therefore, you cannot use a Modifier 57 to pull your E&M out of that global. So let's go over Modifier 57. What is Modifier 57? Modifier 57 is decision for surgery, an evaluation and management service that resulted in the initial decision to perform the surgery may be identified by adding Modifier 57 to the appropriate level of E&M service. Well, in this case, this would not be appropriate because what you did is actually part of the global for the actual procedure. And the best way to avoid that is to communicate with your PA and educate him or her to let you know that, hey, this may be difficult. You may want to see the patient on the day of the initial consult. Set the expectations so that this does not surprise you and it does not surprise the patient. So setting the expectations is going to be very, very important before you perform any surgery. All right. Think of it as a wedding. Think of it as dating. All right. So make sure that everybody's on the same page and that there are no surprises. Okay. So the urologist goes on, actually consults the patient and actually performs the procedure. Typically, it takes about 8 minutes for this particular urologist to perform the procedure. This particular patient, it took 40 minutes. So on the left side, that was normal, which did not have the orchidopexy. The actual vasectomy took about 4 minutes. However, on the contralateral side, it took 36 minutes. And the urologist did an excellent job in documenting why it took so long, separated out typically how long it takes to perform the procedure and how long it took for him to perform this particular procedure. And also, he detailed why it took so long. So he did a great job with the documentation of the actual vasectomy procedure. And he wanted to apply a modifier because it took so long and so much more effort to perform this procedure. So in this case, a Modifier 22 increased procedural services will be indicated in this situation. The urologist did an excellent job in making sure the documentation is complete so that he can bill for that extra work. Now, keep in mind, your billers and coders are going to tell you whenever you use Modifier 22, the payers and insurers are going to most likely require documentation to substantiate the additional payment. And that extra payment ranges. It could be 25%, it could be 50%. It varies all over the place. It varies by payer. Heck, it kind of goes into a black box. You don't know how much extra they're going to pay you. But if you actually did the additional work, I would recommend that you code it and use Modifier 22. the key is to do what this urologist did by clearly documenting why it took so long, extra effort that is used, and also how long relative to the typical amount of time and effort that is needed. So the definition of Modifier 22, increased procedural services, is when the work required to provide a service is substantially greater than typically required, it may be identified by adding Modifier 22 to the usual procedure code. Documentation must support the substantial additional work and the reason for the additional work. That is, maybe that is increased intensity, time, technical difficulty of procedure, severity of patient's condition, physical and mental effort required. And the note at the bottom of this definition says, this modifier should not be appended to an E&M service. This is a procedural CPT modifier and not an E&M modifier. In general, if you want to keep it really, really simple, there are only 3, in general, modifiers for E&M services. And those are 24, 25, and 57. So if you just kind of keep those in the back of your mind when you're using modifiers, they're only really, in general, there are 3 for E&M services. The rest go to CPT. And of course, I'm not talking about modifiers needed for telemedicine services, the GT, the 95, which go on to E&M. We're not thinking about that. Those are exceptions. Those are unusual circumstances. In general, 24, 25, and 57. So just keep that in mind. If you can master those 3 for your E&M services modifiers, that will be awesome. Okay, so at the bottom line, what should you be coding in this situation where it was a difficult vasectomy and the patient, the urologist did an great job on documentation? So really, only thing you've got is 55250, Modifier 22. There's no E&M service. You do not need to use Modifier 24. You do not need to use Modifier 57. Don't pass go. Don't collect 200. Basically, it's just a tough vasectomy that you should have anticipated prior to the patient's arrival. And hopefully, this could be a good lesson for you to improve your communication between yourself and your PA when it comes to patient care. And maybe he or she will let you know and clue you in before the procedure, indicate in a note somewhere, or maybe have you meet the patient on the day of the initial visit so you can set expectations. All right. As usual, if you have any comments or questions, leave them below. And there were some of the urologists had DM me directly wanting to ask about how do we best learn about these E&M services and modifiers and things like that. I have reached out to PRS Network, and I'm working with Scott and Mark Painter to craft a coding course, E&M coding course, just for urologists. Hopefully, we can deliver this in the virtual fashion in July of this year. So instead of waiting till the end of the year for another urology advanced coding and reimbursement seminar, or at the beginning of 2023 for another urology advanced coding and reimbursement seminar, you don't have to wait that long. You can jump in July, and hopefully this will be just giving the nuts and bolts of E&M to help jumpstart your knowledge, acquisition of knowledge, so that you are not leaving money on the table. All right, lastly, for those of you who are going to be in Marina Del Rey in California, attending the UCLA State-of-the-Art Urology Conference, I will see you there this coming weekend. Take care, be well, bye-bye.